Thank you so much.
Well, hello everybody again. When I was making my slides, I was going back and forth whether I should eliminate all the medical jargon. I decided on leaving them on the slide, but when I explain the slides, I will use, as much common language as I can in order for you to kind of get the meaning of the medical terms. I also will provide some basic information on systemic JIA because I'm not sure where the information level is for everybody. I realize that there are some true experts in the room, but bear with me so that people and families of children who were just newly diagnosed also have the benefits of learning. Okay, here we go. So we already talked about the name systemic JIA. And actually the first person who described this disease was Sir George Frederick Still. Turns out he was the first pediatrician in the UK, and he was actually the first professor who wrote a pediatric medical book in the UK. What I didn't know is, I knew that he was describing systemic JIA or Still's disease at that time in 1897. What I didn't know is that he was also the one who first recognized there was something like attention deficit disorder. So he was the man. Over the years, systemic JIA, or how we call it now, has had different names. Systemic onset chronic arthritis was the term used in Europe a lot, and before we used the new classification, it was called systemic onset juvenile rheumatoid arthritis. So what are some of the manifestations of systemic JIA? We already talked about the arthritis, but children with systemic JIA also have lymphadenopathy, meaning swelling of the lymph nodes. They have a rash, and they have organomegaly, meaning the inner organs, especially the liver and the spleen, are larger, and that's why this girl on the picture has a protuberant abdomen, because the inner organs are so large. There are also spiking fevers. There is something called serositis, meaning oozing of the lining of different organs that then lead to accumulation of fluid around the heart and so on. And there's pulmonary involvement, which especially occurs later on during the course of the disease and can lead to pulmonary hypertension, meaning that there is too much pressure in the lungs, so the air exchange is diminished. So let's talk about the rash a little bit more. It's non-pruritic, so typically it doesn't itch, but in some people it does itch a lot. It looks like hives, so it's urticaria-like, and the doctors call it salmon-colored because it's like has this pinkish. Typically when you go to the doctor, it's not there. The rash appears with the fevers, and the fevers, as I will show on a later slide, occur in the late afternoon when you're already hopefully home from your clinic appointment. It has a Koebner phenomenon. What does that mean? It shows up at points where there's pressure around the waistband or around the shoulder straps. And when you do a biopsy and look at the skin, it's not typical for systemic JIA. It shows some non-specific inflammation, as you would see it with many other skin diseases. But you also see some immune activation in the skin biopsy. And on the picture, you see on the slide, you see two pictures of a systemic JIA rash. As I said, there is serositis, which means that there is water around different organs. There's pericarditis or pericardial effusion. That means there is water around the heart. There's pleural effusions. There's water around the lungs. And there can be peritoneal fluid. That means there's an increased water in the abdomen. Most commonly, there is pericarditis, and when that manifests itself as shortness of breath, chest pain, and when the doctor listens to the heart, they hear some special sounds that are called a friction rap. It's diagnosed by an X-ray, and as you may see on the X-ray, the heart that should be normally half the size of the rib cage is bigger, and the reason it's bigger is because there's fluid in the sac where the heart is basically sitting in. One can also do an echocardiogram, which is an ultrasound of the heart. In some persons or children who are diagnosed with systemic JAA, they also can have inflammation of the heart muscle, and that's called myocarditis, but it's very uncommon. So what about the fevers? When you look into the medical chart, they call it a quotidian fever or a double quotidian fever. And what you see is like high temperatures, and then after the fever breaks, it goes down lower than you would normally expect in a person who is healthy. So they are subnormal temperatures. When they happen, those fevers twice a day, they're called double quotidian fever. And typical for systemic JA is that they happen on the same time every day, most commonly in the afternoon. But there are also people children who do not have the typical pattern, who have just constant fevers, who have fevers in the morning, or have intermittent fevers. The only diseases where you get this quotidian fever is malaria or something called leishmaniosis. And what it is that a sandfly basically transmit a parasite, and there you can also get bone marrow involvement. These bugs are not in the United States, so if you have a quotidian fever, it's most likely systemic JA. So when you come to our clinics and when people try to diagnose systemic JA, there is unfortunately, as of now, not one lab test you can do. So you go to the ED and a kid has sore throat, they do a culture and they tell you, oh, that's strep throat, you get antibiotics. The same is not available for systemic JA as of yet. So what it is, it's a diagnosis of exclusion. So you need to basically rule everything else out before you could say most likely it's systemic JA. That's nerve-wracking for the parents, and it also makes doctors very uncomfortable because you always think you missed something. It's very important to exclude infections, because all the immunosuppressive medication we give would make an infection worse, and it could actually kill a child. So we spend a lot of time ruling out infection. We need to rule out malignancies, meaning tumors and cancers. There's another inflammatory disease called Kawasaki disease, which normally lasts 2 to 3 weeks and then goes away. We also need to exclude that and other rheumatic diseases like lupus or periodic fever syndrome, which are related to systemic JA, but that are a little bit different and need different treatment. Because we need to exclude a lot of things before making the diagnosis, we draw a lot of blood and do a lot of cultures. We do blood cultures and urine cultures to exclude infection. We examine the heart. We do different imaging study. Your child may have gotten a bone marrow biopsy in order to exclude a malignancy, or also to diagnose macrophage activation syndrome, and Dr. Scrum and Schulet are going to tell you more about that. If there's a lot of lymph node swelling, there will be a lymph node biopsy as well, just to make sure that there is no cancer in the lymph nodes. And in the future, we hope, with the research we are doing, that we will have more elegant tests so that your children don't have to go through that ordeal anymore. But as of now, that's the standard we need to go through to be careful and make the right diagnosis. Only if you have the right diagnosis can you give the right treatment. So systemic JAA, as per the current rules, is diagnosed by daily fevers or for at least 2 weeks, and they need to have this quotidian pattern, this hectic up and down for at least 3 days. There need to be a rash, in addition to arthritis, as well as serositis, organomegaly, that's the big organs, and lymphadenopathy. And on the orange side, you need to have one of these symptoms in addition to the fevers and the arthritis. So no arthritis, then it's very difficult for the doctors to diagnose systemic JA. There's a subset of children with systemic JA who get the fevers and the rash first, and the arthritis comes later. And in those children especially, the diagnosis may be delayed. And what is shown in very small font is all the infections and other things doctors need to exclude to make the diagnosis. Systemic JAA right now is lumped into a whole group of diseases that are referred to as juvenile idiopathic arthritis. Idiopathic is like a medical term we use for things we don't know where they are coming from, because it sounds better like arthritis and the doctor doesn't know where it's coming from. Idiopathic, you would agree with me, sounds much better, at least to our ears. And right now, there's a whole group of diseases who have immune-induced arthritis where we don't know where it's coming from. And systemic JAA is also lumped in that group of diseases at the current time. Different from the other groups that are in the category, most of the children with systemic JAA are diagnosed, most of the patients with systemic JAA are diagnosed during childhood. Most of people who get other types of arthritis are diagnosed in adulthood. So we do know that about 1 in 1,000 children are diagnosed with juvenile arthritis, and about 10 to 20% of them have systemic JAA. Now, as you can see on that slide, the different categories, and children with systemic JAA are typical in the sense that they have rarely eye disease, they have rarely positive anti-nuclear antibodies, and they don't have a rheumatoid factor. That's the standard test the pediatrician or a rheumatologist will order, and they also lack certain genetic factors called HLA-B27 that are typical for other forms. So what you need to know is that most of the children, or most of the persons who develop systemic JAA during the course of their life or Still's disease are diagnosed very early in their life. So another way to look at it, doctors with pediatricians and pediatric rheumatologists diagnose systemic JAA using something called the International League of Association for Rheumatology criteria for JAA. And as stated before, you need to have typical signs of systemic JAA, and you cannot have anything else like that would be typical for other forms of JAA. So when you look at labs of children with systemic JAA, they're very much different from other children who have JAA, either when they have polyarticular involvement, meaning having more than 5 joints involved with arthritis, or oligoarticular disease, meaning they have 1 to 4 joints with arthritis. In systemic JAA, there's lots of leukocytosis, meaning the white blood counts or the WBC counts, as you see on my chart or my app, is very, very high. There's thrombocytosis, meaning there are a lot of platelets in the blood, and there is anemia, meaning the number of red blood cells is low. The erythrocyte sedimentation rate, or ESR, is a marker of inflammation, is very, very high with systemic JAA, and typically there is no anti-nuclear antibody or ANA. The rheumatoid factor is negative, and as been stated before, there's very often high ferritin, and ferritin is another marker of inflammation, and it also increases with macrophage activation syndrome. So why do kids get JAA? Well, if I could give you a straight answer, I would get a free flight to Stockholm to the Nobel Committee. Unfortunately, I'm not that smart. So how I explain it to my patient is that with systemic JAA, your child has a too strong immune system. It's hyperactive. It's not a weak immune system like in people who have immune deficiency. It's too strong. And why is that? And because it's so strong, it attacks the body and causes this manifestation. And why do we have an incomplete understanding why some children develop systemic JAA. There are some genetic factors, but they don't seem to be that important because otherwise it would be running in families, and we have established that's typically not the case. There seems to be an environmental component to it, which we incompletely understand, and there are probably something else we are still missing, like an infection or so. And that's the task of future research, to elucidate that so we can be more cognizant about the disease and maybe even avoid it to happen. So systemic JAA, because it doesn't run in family, it's not a single disease, gene disease. So when persons have cystic fibrosis, you can do a cystic fibrosis test, and as you know, all the little babies that are born that are stabbed in the heel, and they get a genetic test, and that's how you pick up cystic fibrosis typically, because there is like a screening test. For systemic JAA, that doesn't work. Because there's not one gene, it's more than what we call a monogenic inflammatory disease. We think systemic JAA comes because of the interplay of many different genes, and that's why it's called a polygenic inflammatory disease. And the inflammatory markers that are very much increased with systemic JAA are TNF-alpha, which stands for tumor necrosis factor alpha, because it was first described in persons who had a tumor or had a malignancies, interleukin-6 or IL-6, CTLA-4, which is a marker for the interplay between the B and the T cells in the body, which are important for the immune system, IL-18, interleukin-18, and IL-1, interleukin-1. And on the slides, they provide additional information why we don't think it's primarily a disease of the adaptive immune system, like a typical autoimmune disease where the acquired or adaptive immune system is involved. We think in SJIA, the innate immune system is especially involved, and later on, there is some changes in the adaptive or acquired immune system. So other forms of JIA, in those, like I showed you before, the poorly articulate JIA and so on, the adaptive immune system is very much in charge, and there are immune complex and netosis, and there's B-cell activation. All of those things are less important, but not non-important for systemic JIA. They become very much important during the later stages of the disease or when you have disease for a longer time. Now that's the current model, and now bear with me, I'm going to try to explain it as best as I can. So when systemic JIA or Still's disease starts, it's especially an abnormality or disarrangement of the innate or inborn immune system. And it's thought that IL-1 is really the driver of many of these changes together with IL-6, which is not shown on that slide. And what happens is that there is more adhesion molecules, there's more leukocyte in recruitment and more activation of the immune system, and it also attacks the bones and the joints and leads to erosion, meaning like holes in the bones, and to arthritis, the swelling of the joints. When there is unabated inflammation with IL-1 and IL-6 for a long time, that actually changes the adaptive or acquired immune system, and it pushes it towards the area where there is more arthritis that's similar to that seen with other forms of juvenile arthritis. So the adaptive immune system gets activated and gets pushed in a way that then furthers the arthritis to become chronic. Having said that, it's important to basically really treat the inborn changes very early so that the subsequent downstream abnormalities and changes in the adaptive immune system do not take place, because they may be a little bit differently to treat. And you heard from one of the parents that methotrexate was started, and that's typically a medication we use to treat changes that involve the adaptive immune system. Having said that, it becomes clear that there is a window of opportunity to treat. And that means that it's important to diagnose children with systemic JIA early so that these chronic changes and chronic abnormalities of the adaptive immune system don't happen. Because it has been shown if you have high level of IL-1, IL-6, and TNF-alpha, you get this adaptive immune system changes, and then systemic JIA becomes very much similar to what we see in other forms of JIA. So, having said that, over the last couple of years, the prognosis of systemic JIA has markedly improved because of the approval of new medication like the block interleukin-1 and interleukin-6, and these are tocilizumab, canakinumab, and anakinra, or the medication you already heard today. So what we do know nonetheless, and that's more like a little bit historic information, I like history, I'm sorry, is that we know that there are three basically principal courses of systemic JIA. There are a subset of children, which we think is about 20 to 30%, who just get one bout of systemic JIA and it never comes back. Whether that was true systemic JIA, we don't know. Then there's something called polycyclic course, where you have active JIA for some systemic JIA for some time, then it goes away, and then unfortunately comes back. And there are some, about a third of the patients just have chronically problems with the disease. We know that it's possible that you get into remission, meaning that the disease retreats in children with systemic JIA, but very often, one still needs medication, and very rarely when you are getting off medication does the remission persist. But if you think about it, if a person's immune system, inborn immune system, is set towards being more prone to inflammation, it may make at least a little bit sense that if you take away basically the things that hold the immune system back, that the disease may be coming back. As of now, we do not have a medication to reset the whole immune system. That might be possible with bone marrow transplants, but we are not sure about that. What are poor prognostic factors for children with systemic JAA? If you have disease very early in the disease, very often the prognosis is not as good as when the disease starts later on. If there's lots of ongoing cumulative active disease, meaning if there is no medication the doctors can find to get the disease under control, then obviously the prognosis is not as well. These platelets, basically the part of the blood that makes you stop bleeding, if they are high at 6 months, then that's also a sign of bad marker for prognosis. If you have hip involvement and there's lymphadenopathy, meaning a swelling of the lymph nodes for a long time all over the body, that's also a bad prognostic factor. I show you now some of the old pictures we're hopefully never going to see in children who are diagnosed with systemic JAA at the current time. What you can see over here is like holes in the bone that comes from uncontrollable disease and R1. I told you that R1 kind of bites into, activates the cells that eat up the bones. And you see that there's narrowing of the joint space. That means that the cartilage is gone. And over here, you may appreciate that the neck bones have all kind of grown together, so it's very hard for the children to bend their neck. And that's referred to as ankylosis. And all of those things did happen in the past because we did not have good medication. We really hope to kind of avoid that going forward. What also happened with the prolonged need of steroids or when medications like tocilizumab or anakinra or canakinumab don't work is that you have growth delay. And on the slides, you see two twins. One of them had systemic JAA, and the other one did not. And that's a historic picture. And as you can see, the child with SJIA has the walker, and is really very short, and so she has a generalized growth delay. And on the right side, you see another kid with systemic JAA where the jaw is going back, and that's localized growth delay because the arthritis impaired the growth of the mandible. So what it becomes clear is that we need to control the disease to avoid this generalized growth delay. One can give growth hormone to children with systemic JAA, but it has been shown that it only really works well when the inflammation is under control. What about mortality? Well, children with JAA die, and actually the ones that die the most, unfortunately, and again, that's historic data I'm showing you here, are those with systemic JAA. So when you look at all these children of JAA, 2/3 of them die because they have with a diagnosis of systemic JAA. Obviously, children with polyarticular JAA or porphyria oligoarticular JAA die too, but it's more common with systemic JAA, and that is just a reflection of the severity of the disease. Why do children with systemic JAA die? They die from infection, and again, that was more common in the past when we needed very high doses of steroids that basically make the likelihood of an infection to occur much higher, with macrophage activation syndrome because of heart inflammation and amyloidosis. And what's amyloidosis? Thankfully, that's something that's very rare in North America, but what it is basically a protein, it's shown here on pink, that goes inside the organ and makes them very hard and not function anymore. What you see over here is one of the filters you see in the kidneys. It's referred to as a glomerulus, and all the pink stuff shouldn't be there. And because the pink stuff is there, the filters in the kidney don't work anymore, and they are basically leaky, and that's why there's protein in the urine. The same thing can happen in the liver. Then you get liver problems. It can happen in the gut, and then you get diarrhea, and also it can go into peripheral nerves, and then you get basically tingling of the nerves. This amyloidosis was very common, especially in Europe, when the inflammation with systemic JAA has not been controlled. Again, it's very rare in North America, and it can retreat with control of the inflammation. And there are reports, especially out of Europe, where the amyloidosis went away after the biologic therapy was started. So taking Summarizing up, I hope, or I know you all are aware that systemic JIA is the most severe form of JIA, and all pediatric rheumatologists are vividly aware of that. Because of the severity of the disease, it affects not only the patient, it affects the whole family, it affects the siblings, and very often it's associated with a need for very intensive therapy and it's very expensive to treat. There are some additional statistics on it for people who like numbers, but in the end, it really comes down to the fact that we need to take care of your children with systemic JA, and all the statistics don't really matter because we need to treat the individual child. I thank you for your attention and open for questions as you may have them.
Me better?
Yes.
So in the beginning of the disease, the innate immune system is involved, and later on, the adaptive immune system can get involved as well. Is there any way to tell if that is happening in an individual child? And if that does happen, then do the medications that are used change?
They do change. I'm confident that Dr. Grom going to go and address the topic a little bit closer. A sign is, for instance, that you have more arthritis and the systemic features are less prevalent. Then medication that help are etanercept or Enbrel, methotrexate. And typically for the systemic features, methotrexates are not very good. And etanercept is not as good as a medication either.
Okay, thank you.
You can do some genetic and cytokine profiling to look at the involvement of the adaptive immune system, but it's also become apparent from the reaction of the patient to the medications.
Okay, thank you.
Make sure it was on this time. I guess I'm always surprised when I hear families go to hospitals, they talk to rheumatologists, there's unfamiliarity with the disease, and they have difficulty. Could you explain to us why that is? It would seem to me, it would seem to a layperson that somebody goes to a rheumatologist, they should know about this disease. Is that the education of the physicians? Is it something that you just have to specifically specialize in and know that that's what you want to get into from the beginning? Can you explain that to us a little bit?
Okay. So pediatric rheumatologists are a rare breed. There are only about 250 practicing pediatric rheumatologists all over the country. There are actually, I think the last time I looked, 6 states in the United States who do not have a single pediatric rheumatologist. Because of that, it comes to a delay because you really count on the pediatrician or the people in the hospital to think about pediatric rheumatology. And because there are not so many pediatric rheumatology centers, most medical students are never exposed to pediatric rheumatology. And if you never learn about it, it's very hard to remember things, right? So that's one of the problems. About 50% of children with systemic JIA actually taken care of by adult rheumatologists who don't see systemic JIA often because most of the children who have the symptom complex really are diagnosed during childhood and end up more with oncologists and infectious disease people. I dare to say that most systemic JIA patients in the end or family make it to a pediatric rheumatologist because adult rheumatologists generally feel very uncomfortable treating them. It's very complex. They see a lot of rheumatoid arthritis and osteoarthritis, and there is the one small child with systemic JIA, so normally they get sent off. However, there are lots of families who live far away from a pediatric rheumatology center. And then it becomes difficult to receive appropriate care early.
So I thought that was interesting. You mentioned about the adult rheumatologist seeing children. How different is the way Still's disease is treated from the way that systemic JIA is treated? Because our understanding is it's basically the same mechanism, possibly just the same disease, but when the patient gets it is the differing factor.
Well, there are two comments I'd like to make. I'm on the Speakers Bureau for tocilizumab, and I give a combined program with adult rheumatologists, somebody who is very experienced in the field and does lots of clinical trials. And I'm almost amazed how little they know about systemic JA and JA in general. You would think that, like opinion leaders would be very familiar with our disease, but it's not. They really see them very rarely. And if you're only exposed to a disease very rarely, you're not familiar and you're not even able to pick up the patterns. Still's disease, an adult onset Still's disease, scares the adult rheumatologist, and Dr. Graham probably gets 3-4 frantic phone calls every week and say, I think my patient has adult onset Still's disease. What should I do? Could you see him? So it's very scary to them. And it's just a very rare disease. JA by itself is a disease in 1 in 1,000. But systemic JA is 1 in, it's 10 to 20%, so it's 1 in 10,000.
Yeah.
Or even.
Still's disease, how common is Still's disease?
Oh, probably 1 in 100,000.
So it's less common.
Oh yeah, it's very much less common. See, Still's disease is one of the diseases, for instance, canakinumab, it's approved for systemic JIA, but it's not approved for adult onset Still's disease as far as I know, because it's so common in children. It's one of the few diseases where all the clinical trials have been done in children rather than in adults, and then one study is done in children. It's the other way around normally.
Mm-hmm. So are the IL-1 and IL-6 blockers not used for treating Still's disease because of that, or are they just used off-label?
Well, they use it off-label. Most of the medication we use in pediatric rheumatology are off-label. So, we are basically left to our own to figure out what is the right dose and how often do you give it. It doesn't make anybody feel comfortable. And just most recently, the first medication that were approved for systemic JA actually were canakinumab and tocilizumab. Anakinra is not approved for systemic JA. It's used for it. It's the, many of the insurance company let you use it.
I know our insurance denied it like 4 times before we could get it.
Yes.
So.
And it's now more favored to canakinumab because it's cheaper, but, normally you have to play this, chicken game and, start a medication, prove that it's not working. So tocilizumab and canakinumab are the first medication approved for systemic JA. We use steroids, but they're not approved for systemic JA. Okay.
I have a couple questions, actually. Number one, so our little girl's 5. She's been resistant to everything. Ilaris, Kineret, Actemra, Enbrel, none of them are really working for her. She's on 9 to 12 milligrams of steroids a day. The question I have, number one, we never actually, when she was diagnosed kind of based off of symptoms and some tests, but we never went through it's been about 8 months now, we never went through the process of actually, she's never had a bone biopsy, never had an echocardiogram, never gone through all of that kind of stuff. So one question would be kind of, okay, is that probably an error and maybe why we're not seeing responses to what she, to maybe any of the medications? The second question I have regarding your presentation that just made me curious, my father received a heart transplant in October for cardiac amyloidosis. Is there, I know we're talking about a one-way path of maybe having this SJIA lead to amyloidosis. Is there any correlation going the other way up that street in the sense of are people in any way, is the fact that there may be, and from my understanding, my dad has a rare type of amyloidosis, and what they originally thought he had, his actual protocol, what they thought he had and its behavior, it's not turning out to be so much that way. Is there anybody studying, or is there anything we should be looking into as parents as far as the relation between my father and my daughter?
It's possible. I can't tell it for sure. I know that Dr. Grom and Dr. Schulert will touch on that. You only, there's a whole spectrum of what we lump currently under systemic JA. And there are some children who only have one bout, and there's